Hello again, everybody. It's again Dr. Al Hewer. This part of our ACCS exam review will focus on the fundamentals of hemodynamic monitoring. So without further ado, let's get started and let's look at some learning objectives. So we're going to describe the functional anatomy of the heart. So as we talk about in some of our other modules, including the one for EKGs, we talk a little bit about anatomy because it's real helpful to understand the normalcy and some of the abnormal events that can happen in ECGs, but now in this case in hemodynamics, it can be quite important to understand some of the basics of the functional anatomy of the heart. I don't mean to imply you guys don't understand it, but it's probably a good review. Detail measures of the hemodynamic monitoring, including cardiac output. We'll review factors which can impact cardiac output and hemodynamic monitoring. Review interventions for hemodynamic abnormalities. And as we do with essentially all of our presentations, furnish you guys with additional resources if you want to drill down and review more on this. So the reason why I included this slide, it really, it's reminding us, we learned it, is reminding us of the flow of blood through the cardiopulmonary system. And the importance of it in terms of hemodynamic monitoring is, for instance, when the right heart is failing, it's predominantly the right heart. Granted, we can have elements of both happening simultaneously, right and left heart failure. But when it's the right side of the heart, what we're going to have is we're going to have blood backing up into the right atrium, into the right superior vena cava, and therefore pressures such as our central venous pressure will be particularly elevated with right heart failure. Will be, most pronounced. It'll be elevated, and the patient will, in all likelihood, exhibit other symptoms such as pedal edema, such as increased jugular venous distension, and other anomalies as well. Conversely, or in addition, when it's the left side of the heart that's failing, particularly the left ventricle. So what you're gonna have is a backup into the left atrium, a backup into the pulmonary vessels, and if that is pronounced enough, so those pressures, the pressures that emulate, such as pulmonary capillary wedge pressure, which we'll talk more about, which emulates left atrial diastole, so that pressure will be very much elevated. And as you go further back, such as pulmonary artery pressures will also be elevated. You go further back, and even pressures such as central venous pressure, which is way upstream, may well be elevated. Not to the extent that you'll find that the pulmonary artery pressures and pulmonary capillary wedge pressures are elevated, but you'll find that they'll be elevated as well. With left heart failure, the symptomatology that will ensue would be things like, think about what's happening. So the pressures are backing up into the pulmonary vasculature, causing leakiness, causing fluid, if you will, to go from the vessels, the vascular space in the vessels, across the alveolar capillary membrane into the lungs. So that these patients develop this, pink, frothy fluids or secretions or sputum that we often see with left heart failure. So let's again, and this image is just depicting that flow that may help, if you will, explain and help you guys remember, if you have forgotten, how those right and left heart failure can affect some of those pressures. Remember, to oversimplify, the flow of blood through the cardiopulmonary system is a plumbing system. And what happens when a pump is not functioning properly is you get backup. And the backup is measured obviously through various symptoms, but also through changes, most commonly increases in various pressures. Most, in relation to, again, right versus left heart failure and those pressures that are measured immediately before the right and the left heart. Amount of blood, so cardiac output, quick. Amount of blood pumped out of the ventricles per minute. Again, stroke volume times a heart rate. And again, typically in that 4 to 8 liters per minute at rest, cardiac output, normal cardiac output. Cardiac index is your cardiac output, but in relation to body surface area. So determined by dividing the cardiac output by body surface area. Normal cardiac index is 2.5 to 4.0. And again, they'll give you, you're expected to know that, but you're also expected to know that if cardiac index is, 2.3 on a patient, it's somewhat low. It's not, it's significantly low, but also what kind of symptomatology the patient might be depicting and what sorts of hemodynamic measurements what you expect. And again, most commonly in left heart failure, you would expect those pulmonary artery pressures and pulmonary capillary wedge pressures to be significantly elevated. Ejection fraction is the percentage or fraction of end diastolic volume ejected with each heartbeat or each systole. Normally, it's about, some of the books even say 60 to 70, but around 65 to 75%. But of course, it drops with cardiac failure. So it's, all of the blood is not ejected, but it's crudely put about 2/3, maybe approaching 3/4 of the blood in that left ventricle is ejected with each beat normally. Heart rate, so it's a compensatory mechanism, decrease in heart rate associated with increase in stroke volume with all else constant. Again, stroke volume has to do with do not memorize Frank-Starling's law, where it talks about stretch. And that really has to do Frank-Starling's law has much to do with stroke volume than it does with heart rate. Ventricular filling and tachycardia, various dysrhythmias that we've discussed in other modules for this review. And heart rate is primarily determined by the central nervous system, okay? Primarily, not exclusively. So we have the autonomic nervous system that's, helping dictate it. But we also know, and we reviewed earlier in this review, that the heart does have its own internal pacemaker, which obviously plays a role as well. Heart rates greater than 160 to 180 is the exception, yielding decreased, end diastolic volume, basically decreased cardiac output, but increased oxygen uptake, which is a dangerous combination. Cardiac output cycle. So, just gonna really not spend a ton of time on this, but this is just depicting the various, if you will, stages that are occurring within the cardiac cycle. Obviously, each of these correlate with, different electrical depictions of in ECG or an EKG. Also included in an earlier module for this review. Preload, stretch on the ventricle before contraction. It's to do with filling, so it's filling. Venous return certainly plays a big role. So, we talk about PEEP, and in other modules in this review, we talk about excessive PEEP, reducing venous return. So obviously, because it reduces venous return, it could absolutely affect things like stroke volume and cardiac output. Compliance here, we're not talking about lung compliance, we're talking about compliance of the myocardium, of the heart wall, or heart muscle wall, if you will. And what happens, one of the things that happens with compliance with patients that have repeated myocardial infarctions is that compliance goes down because now you have injured and scarred over, heart muscle. So it becomes less, it becomes a much less efficient pump. Common drugs that affect preload, so tipping our hand for the review that will go over the pharmacologic interventions. So drugs that reduce preload, nitroglycerin, diuretics, including Lasix, but not only Lasix. Lasix being what's known as a loop diuretic. Loop operates in a loop of Henle. It's very potent a diuretic. And if a patient has, something that remotely appears to be normal kidney function, when they're given Lasix, they will urinate quite quickly and dramatically, dose dependent. So doses of Lasix, and I'll go over this more in other modules, typically a baby dose would be, 20 milligrams, 40, 60, 80 would be a lot. Bear in mind with Lasix, your loop diuretic, you got to be careful of your potassium. because you could be, you could deplete your potassium. So something to be aware of is, and then you're, fixing one problem, maybe contributing to another. Morphine's another one that causes, vasodilation. Drugs that increase preload, fluids. So your fluid bolus is something we do for patients that, a certain group of patients that are, hemodynamically unstable on the low end of the scale. Blood products, and then some of your volume expanders, such as colloids, crystalloids, such as those that are mentioned here. Afterload, resistance to ventricular emptying, two components, peripheral vascular resistance and ventricular wall tension, flexibility, if you will, compliance. Increases with vasoconstriction, increase in the oxygen demand, decreases with vasodilation, improves stroke volume, issues with blood pressure if the volume is low. Blood viscosity plays a role. Why do we care about blood viscosity? Because patients that have, if they have polycythemia, particularly secondary polycythemia secondary to chronic mild hypoxemia due to like COPD, their blood tends to be thicker. And it's harder to pump. So the good news is it has more red blood cells. The bad news is that it's literally thicker and harder to pump. Negative interthoracic pressures can also play a role with afterload as well. Common drugs that affect afterload, they reduce. So nitropres, Vasotec, and Capitan would be amongst them. And ones that increase afterload, epinephrine, norepinephrine, which is also levophed, and dopamine. So again, some that reduce, some that increase. Contractility, strength of ventricular contraction, really relates most closely to the sympathetic nerve stimulation. Inotropes, by definition, increase, if you will, the pumping activity of the heart. Inotropes. Physiologic depressants such as hypoxia, hypercapnia, acidosis, and coronary flow. Also, what can affect contractility, or not just coronary flow, but also heart muscle damage, as I alluded to earlier, as you might see in the case of one or more significant myocardial infarctions. Drugs that affect contractility. Calcium, DIG, epinephrine, norepinephrine. So you think about norepinephrine or levophed is not just a vasoconstrictor, but it also increases the squeeze, the pump. So it does a couple things. Dopamine, dobutamine, amiodarone, isoproterenol, which is now not given as a bronchodilator in this country anymore, but can be given in rare cases as a positive inotrope. Caffeine, believe it or not, is one as well. So those methylxanthines also fall in that category. Negative inotropes, beta blockers, propranolol being one of them, but there's others. Barbiturates, procainamide, and quinidine. Stroke volume affected only by preload, contractility, and afterload. Just kind of the basics on the side. So volume ejected by the ventricle with each contraction. Okay. So contract B equals systole. Stroke volume equals end diastolic volume less end systolic volume. And then we just show preload, heart contraction, afterload, kind of like the sequence. Pulse pressure, difference between systolic and diastolic. Normal pulse pressure is about 30 to 40 torr. A pulse pressure less than 30 torr indicates or suggests a low stroke volume. Or, again, low pumping by the left side of the heart, left ventricle. If blood pressure increases with the fluid therapy, patient is probably hypovolemic, so they're fluid responsive. Fluid responsive. You'll see they may give a fluid bolus in order to help make that determination. Did the patient respond to it? Factors that affect venous return, cardiac output, and preload, changes in circulated blood volume. We have to do with hemorrhage, loss of volume, such as you see in dehydration, so inadequate fluid intake, or excessive diuresis. Gain on volume, so IV colloids can also have the effect, certain like colloids can have the effect of increasing onconic pressure. So the patient will retain those fluids in the cellular space owing to increase in onconic pressure. The tendency for the cells to want to reabsorb fluid. Changes in distribution of blood volume, third spacing, burns, sepsis, and shock, changes in body position, venous tone. So that's how constricted or dilated the actual walls of the vessels, particularly the veins, are, and intrathoracic pressures. Atrial kick contributes up to 30%. 30% is high. I know that's what I have here. That would be an extreme, but a lot of the books say 15 to 20% of total cardiac output, as much as 30. Positive pressure ventilation. Positive pressure ventilation in and of itself can aid cardiac output. It's PEEP that can diminish it. Be clear on that. Changes in preload. So increases in preload, leaky valves due to stenosis, or your mitral valve, your tricuspid valve. It's ironic a little bit. Your mitral valve's on the left side of the heart, but it's only got 2 leaves normally, at least. Tricuspid valves and on the other side, and it's, you would just think, I just intuitively, I think it would be the opposite, but it's not. So mitral valve stenosis, that's the main pipeline that's actually, ejecting blood from the left ventricle. When that becomes both stiff and smaller, it can absolutely, affect your preload. Decreased heart rate, increased stroke volume. Decreased preload, hypovolemia, increase in heart rate. So you're kind of reversing some of those elements on the bottom there that relate to increase in preload. Decreased stroke volume, increase in intrathoracic pressures. Increase in intrathoracic pressure could well be things like, when I say excessive PEEP, typically north of 10, 12, 15. Positive pressure ventilation, normal spontaneous inspiration augments preload. As we alluded to earlier, augments cardiac output. Effects of lung compliance. The effects on venous return depend on how much pressure is transmitted to the pleural space. So stiff lungs, simply put, don't transmit a lot of pressure to the pleural space. Floppy lungs, like you might have with a patient who has like severe emphysema, where they've lost a lot of elastance, the opposite. A lot of it's transmitted. PEEP/CPAP decreases venous return. ICP, depending upon what section of the brain is affected by the increase in ICP, assuming there's not just increased ICP, but also an injury somewhere in the brain causing, that increased ICP, can have a variable effect. A little bit on Frank Starling, a little bit here. So really, looking at what can happen with the contractile state being diminished in D with an extreme example of cardiac shock. And then all the way up, kind of near the top there, A is what you'd have with, again, your contractile state being high in the case of an individual normal during exercise and has a good compensatory mechanism where their actual stroke volume, not just the heart rate, but the stroke volume increases in normal response. Cardiogenic shock, not so much, D, or not so much at all. Heart failure, not so much. Normal is B, your normal kind of living your life, etc. And then the compensatory mechanism in A that you see there as well. Why do we use hemodynamic monitoring? So, and now we've gotten away from the kind of the foundational stuff. And, so we want to, relate back to intravascular fluid volume. Is the patient too depleted? Are they overloaded? Looking at things like CVP and pulmonary capillary wedge pressure. Cardiac function, cardiac output, and cardiac index. And then vascular functions such as peripheral vascular resistance and systemic vascular resistance. Let's look at central venous pressure. Pressure of the blood in the right atrium or the superior vena cava, the portion of the superior vena cava that's entering the right atrium. It represents the right ventricular and diastolic or diastole pressure, or right ventricular preload obtained by a central venous catheter. Central venous catheter, quite frankly, the one that I'm showing here is a triple lumen catheter. They are often triple lumen, but they don't need to be. On the right-hand side, we're showing you basically, the central line or central venous pressure line, and kind of it's threaded. You can see it's really at the very distal end of the superior vena cava, almost, in that, essentially looking like it's in the right atrium or just entering the right atrium. And you have it increasing with increased venous return, hypervolemia, increased with intrathoracic pressure, such as positive pressure ventilation, increasing with right ventricular failure. So as that right ventricle gets weaker, it will cause a backup, initially just less being ejected into the pulmonary artery, which is really a vein, and more ultimately backing up in the right atrium, expressed in terms of increased central venous pressures. Will decrease with decreased venous return, as we see with excessive PEEP. In a acute situation, even a pneumothorax, decreases with a decrease in intrathoracic pressure, spontaneous breathing, and increase in myocardial contractility. So you get better heart function, less backing up. So you get the idea. Fick equation, here's the deal. Don't want you to memorize, nor do I think you should sit here and say, oh my God, I forgot Fick equation. This is what I want you to think about. Okay. The Fick equation is all about this, right? It is used to calculate cardiac output. And the basic premise under which it operates is this. At all else constant, if all else is constant, as cardiac output drops, the difference between PA and PV, or SA and SVO2, will widen. It will become greater. The reason why it will become greater in a fairly predictable manner. The reason why it'll become greater is that the PaO2, or partial pressure of arterial blood, as cardiac output drops, the tissues need what they need. Remember I said all else constant? If there's less blood going to the tissues, there's going to be more offloading of oxygen. Therefore, the blood will come back. The venous blood will be more depleted. That's what the Fick equation is all based on, okay? It's all based on it. I mean, I'm not a big equation guy myself, but it is what it is. So again, look at the slide. So the Q is cardiac output. The amount of blood from the heart, 1 minute represents, O2 delivery. Okay, the difference, the A minus VO2 difference is the difference, the amount of oxygen in the arterial blood compared to that in the venous blood, right? Which will become, the difference will become greater as cardiac output drops. Thermodilution, so it's not funny, but the interesting thing or not is that, pulmonary artery catheter lines, or called Swan-Ganz by some. So it's not a central line, it goes threaded further through the heart. And I'll show you that in a few slides, all right? The Swan-Ganz catheter, okay, they're not used as widely as they once were. 20, 25 years ago, you walked into most any ICU, in other words, not a cardiac ICU, they had a Swan in place. Now, they're pretty commonplace in cardiac ICUs, okay? And post-open heart units, that sort of thing. But they're not commonly used elsewhere because we now have other methodology to measure and estimate things like cardiac output that are much less invasive, that can even do some of this off of an A line, okay? Meaning what we do with that information, the A line, is much more sophisticated than 20 years ago, all right? However, the MBRC will still expect you to know Swan-Ganz catheters, okay? That's really where they're focusing. So thermodilution procedure measures the temperature of the change of blood following the injection of a solution of a different temperature, of a cooler temperature. Warming, how fast that solution that's injected warms from one port to the other. The higher the cardiac output, the more it'll warm. Okay, again, simply put, specific quantity of saline, or D5W, at iced or room temperatures ejected rapidly into the proximal port of a thermal-dilution pulmonary artery catheter. The temperature drop of the blood is measured at the distal tip of the thermistor. We're going to expect you to know that, just kind of rudiments. So if you need to, pull out your old edition. And by the way, this stuff is still applied to, 5 editions ago with Egan's. We're the 12th edition is out now. We're working on the 13th edition as we speak. But some chapters change a lot. This chapter on hemodynamics changed because it recognizes the addition of some of the new methodology. Okay, so it has changed, but they still talk extensively about Swan-Ganz catheters. So, and hemodynamics. So I strongly, and I'm not trying to sell, take your old edition, take the 6th, 7th, 4th, whatever edition of Egan's you had, take it out. And when it talks about Swan-Ganz catheters, read up on it if you're a little bit hazy on it. Temperature drop of blood is measured the distal tip of the thermistor. The temperature is plotted and cardiac output is calculated. It's called shooting an output. It's not continuous, it's an event. A lot of the technology we have today will give you cardiac output on a continuous basis. Okay. This was at various intervals. They would shoot a cardiac output in order to determine it. So in addition to Fick is using an equation, doing it indirectly. Thermodilution is indirect, but it's pretty accurate if well done. A little bit on the actual anatomy physiology of a Swan-Ganz catheter. Notice this one has 4, not 3, 2, or 1. It has 4 lumens. Okay, so you want to just kind of familiar yourself with the actual lumens, the port, okay, what the ports are, what they're used for, and those sorts of things. Of course, I'm going to talk, I've already talked about it, but I'll talk more about it as well. But it's important that you spend the time reviewing the stuff if you're hazy on it and prep for the exam. It's not so much knowing that, even though when I took the ACCS exam, they actually had information regarding that the Swan, the millimeter marker was X. And I remember scratching my head saying, in other words, where it was secured. And the point they were getting at was it was not properly flowed. It wasn't positioned. The distal lumen was not positioned where it should have been in zone 3 of the pulmonary artery. It was not advanced enough. And the key there was they actually told you at what point it was secured. So it wasn't advanced enough. And I remember scratching my head saying, man, oh man, how long, what's the distance? How long is a Swan-Ganz catheter? You didn't need to know that to get the right answer, by the way, but you just had to read the whole question. And if you knew that bit of trivia, it kind of positioned you to, towards the right answer. But now, refamiliarize yourself, review the anatomy of a Swan-Ganz or, pulmonary artery a catheter. A little bit more on it here. This is actually shooting a cardiac output. I'm going to give you a little bit more to showing you that where they're a bolus injected into the proximal lumen and then ejected, that it enters the right atrium, etc., and then where it's actually measuring the change in temperature, which again, all else constant can correlate very nicely to cardiac output. Complications, some of them are obvious, some of them aren't. So trauma, anything, pneumothorax, it's not common. But one of the main issues with this is they'll do something to the heart, or they'll actually, when they're inserting it, they'll cause a pneumothorax. So it's almost the standard of care is basically to do a chest x-ray when they're done doing this. But trauma, hemothorax, pneumothorax, nerve damage, dysrhythmias, because think about it, you're threading it through the heart. If you tickle, you tickle part of the heart, that's, where there's a conducting pathway, could absolutely give you some dysrhythmia. Heart and or pulmonary artery perforation, oh my dear, don't want that. Embolus, thrombus, hematoma, infection. Pulmonary infarct, where talking about there is something happened. There could have been some plaque on the pulmonary artery, which is really a vein, that was flecked off, and now it has resulted in a downstream pulmonary infarction. Not good either. Dislodgement or migration of the actual, the catheter itself can be an issue. Less alternative methods. So I'm not going to dive down this rabbit hole, okay, but just be aware, almost more clinically than for the MBRC. Pulmonary artery catheters and central venous catheters also plagued with complications, risks, inconsistencies, they're expensive. The main thing is, source of infection, It's going through the heart, so you can see it's going through the valves and stuff. So yeah, therefore less expensive commercial products have become introduced. They include, pulse pressure variation, stroke volume variation, and oximetric waveform variation. Don't spend a lot of time on this, but there's one other method that warrants discussion is thoracic bioreactance. Okay, thoracic bioreactance uses non-invasive electrodes and alternating current voltage across the thoracic cage in order to obtain a signal which correlates with aortic flow to calculate cardiac output, cardiac index, volume, and responsiveness. Okay, again, more for the sake of completeness. People do not spend a ton of time on this. However, complete evaluation is beyond the scope of this. When to monitor: unstable cardiogenic pulmonary edema. So your CHF patients, hemodynamically unstable ARDS. It could be hemodynamically unstable septic shock, major cardiac and thoracic surgery. So again, cardiac and thoracic surgery, almost all of them, particularly cardiac surgery, are going to have a Swan in for a couple of days. Cardiogenic or septic shock. So relating to that, really the hemodynamic instability that can accompany that. And then a little bit, venous system blood flow, a little bit correlating these different measurements with, what system, and, a little bit more on, the blood flow there. Filling pressure, so right heart, giving you a little bit more on what these values are. Filling pressure, right heart, right atrial pressure, also known as central venous pressure, 2 to 6 torr. Know it, period. Not that don't mean to condescend. If you're a little hazy on it, 2 to 6. Okay. Left heart, filling pressure for left heart. Again, the pulmonary capillary wedge pressure emulates it is 6 to 12. 6 to 12. Pulmonary wedge pressure or pulmonary capillary wedge pressure, same difference. Same difference. This slide, I would spend some time on it. This is right out of, again, your Egan's. If you're a nurse, your nursing textbook, Egan's happens to be the cornerstone textbook for respiratory therapy still in the education realm. It's fine. A lot of good sources, have this stuff in it. And you can pretty much open any really comprehensive nursing textbook or our cornerstone, Egan's, my clinical assessment textbook, and a lot of other really, Dean Hess's book has some really good depictions of this as well. You need to know, it's not just to memorize, is these values that your central venous pressure, 2 to 6, your right ventricular pressure of 20 to 30 over 0 to 5. Let's say 25 over 5, right ventricle, okay. Pulmonary artery pressures, again, 20 to 30 over 6 to 15. So let's just say 20 over 12, okay, with a mean. Pulmonary capillary wedge pressure, 4 to 12 torr. Point is, know what these are, but also know when the plumbing system is backing up, when it's the left heart, okay. Pulmonary capillary wedge pressure and pulmonary artery pressure will be significantly elevated. Your right ventricular and your right atrial pressure, your central venous pressure may be elevated, but less so. If the main problem is right heart failure, your central venous pressure of 2 to 6 will be way high, because that's where the problem's occurring, all right? And then, other things, symptomatology, as I said earlier, ankle swelling, jugular venous distension. But your pulmonary artery pressure and your pulmonary capillary wedge pressure may be low because they're receiving less, the left heart is receiving less blood flow from the right heart, which is failing. Okay, so just think of the pump. Think if that pump is failing, whatever's downstream from it, okay, downstream, so that's, it's not going to receive as much, okay. If right heart, it's going to back up before the right part of the heart. So this is kind of showing you a lot in this slide. The bottom part shows you the pressures. The middle part shows you the graphical depiction. The upper part shows you where the tip of the Swan-Ganz catheter is at that point in time. So in the olden days, probably still today, they would tell as they thread a pulmonary artery catheter through the heart. They can tell where it is many times by the pressure that it's reading. So definitely spend some time just reviewing this. It's also going to help you kind of identify right heart versus left heart failure and the extent of it. Pulmonary artery pressure interpretation. So, pulmonary vascular resistance caused by PE, obstruction, acute chronic lung diseases, cardiac tamponade, etc. Okay, versus decrease in pulmonary vascular resistance caused by the elements that I have listed here. Pulmonary capillary wedge pressure interpretation, left ventricular failure, this will be elevated, mitral valve defects, regurgitation and/or stenosis, hypervolemia, which would affect, if it's hypovolemia, pulmonary capillary wedge pressure would be low. If it's hyper, it would tend to be high with all else constant. PEEP, again, your cardiac PEEP, excessive PEEP is your cardiac output. Your pressures are high, but your cardiac output's dropping. And your equipment. So note, if your pulmonary capillary wedge pressure is greater than 18, mild pulmonary vascular congestion. If it's greater, acute pulmonary edema. So, this one is really kind of showing you these slides, these past few slides are really rich with information. So right ventricular failure, it's giving you an idea of what's elevated and why it's elevated. So right ventricular failure, increase in CVP, increase in vascular congestion. Left ventricular failure, more increased pulmonary capillary wedge pressure and pulmonary artery pressure. The increased CVP would be increased, but not to the extent, proportionality, that it would be in right heart failure. Increased lung pressures, so increased pulmonary artery pressures be associated with increased capillary, central venous pressure rather, and increased vascular congestion. So how do you manage these patients? Dizzying. Oh my God! So now I finally spent all this time to review, and I used to know it. I forgot it because I haven't used this stuff in a while. And now I got to study that. And now what? Now you're going to be expected to make some basic recommendations. Okay, so some hemodynamic monitoring, just by virtue of the fact of really looking at, in certain cases you're doing nothing. Okay, I mean monitoring patient. Is the patient preload responsive? Okay, if they are, does the patient have reduced vasomotor tone? No. I'll give you an idea of what to add vasopressor. And then if the answer, again, depending upon where they are, if it's yes, you add a bolus, add a vaso, volume, bolus, and vasopressor. Okay, so this is saying it's more, it's more significant, so you need to do more than one thing, and then so on and so forth. Doesn't mean you got to know all of this stuff, okay? But just beware that if the patient's hemodynamically unstable, particularly in the low end of the scale, are we causing it? Is it excessive PEEP? If we're not causing it, and it's just a progression of the disease, they have multiple system failure because of ARDS, or they have something, they have septic shock, fluid and vasopressors, such as Levophed, and obviously you want to treat the underlying infection with the appropriate antibiotic or things that you should be recommending. Some review questions here. Okay. So we have a patient has a pulmonary capillary wedge pressure of 20. Okay. Of 20. Okay. Then we said it's going to be somewhere, 4 to 8-ish, something along those lines. So it's elevated. Which of the following does this measurement likely indicate? Left ventricular failure. I know I have that one obviously marked. Tricuspid valve stenosis. That's on the right side of the heart. Hypovolemic shock. It would be low. Pulmonary vasodilation would be low. Okay. So normal pulmonary artery or pulmonary capillary wedge pressure range from, depending upon which book, 4 to 12, 6 to 12. Elevated pulmonary artery wedge pressure is often observed. Left ventricular failure, cardiogenic shock, hypovolemia, blah, 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 blah. But this is the chapters that talk about hemodynamics aren't just going to talk about measurement. They're going to talk about the causes and some of the basic treatments as well. Pulmonary artery wedge pressure may also be elevated above normal with application of positive pressure ventilation, especially when combined with PEEP. Mainly the PEEP part would do it more than the positive pressure ventilation. To assess gas exchange at the tissues, you would sample blood from which of the following? So just for a minute, I know I got the whole questionnaire, I got the answer, et cetera, et cetera. At the tissues, you want venous blood. Reason why, just taking it down to chase here, because I know we have limited time. You want venous blood Okay, because remember what I said about Frank's, not Frank Stoner's law, I apologize, but about the Fick equation. The Fick equation has to do with all else constant, how depleted does that venous blood come back? And where are you going to sample venous blood? In this case, pulmonary artery, that's an artery. No, the pulmonary artery is really a vein. I didn't make this stuff up, so I can only do what I can do here. But look at your choices here. So let's read the explanation now. So the right answer is pulmonary artery. To assess gas exchange at the tissues, we need to assess blood flow after it leaves the capillaries and heads back to the lungs. For the body as a whole, we need to wait until after all the blood from the capillary beds mixes together, mixed venous, which is complete only in the pulmonary artery, the only artery in the blood which carries venous blood. So you talk about, oh, the central vein. The central vein is not going to be mixed venous. It's not going to be mixed venous. Talking about tissues. They didn't say tissue here or tissue there. They're talking about tissues. Closing note on this question too. Remember, pick the best answer. The best answer. The best answer here is pulmonary artery, just to be abundantly clear. Could you scratch your head and say, well, it's venous? Al Ewer said, something with the veins, blah, 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 blah. But you need mixed venous. You look at the question, it says from, basically guessing at the tissues, not the arm, the leg, the foot, whatever. PA port, mixed venous sample. Through which pulmonary artery catheter port would you obtain mixed venous blood sample? Okay. You can read, proximal port. So this plays to, you just need to re-review these different ports. If you're going to take this exam, you have to go crazy with it, but have a basic understanding. The catheter thermistor connector, the distal catheter tip port, okay. The balloon inflation port. Take mixed venous samples from the distal port of a pulmonary artery catheter. Remember, that's where the end of this, of the pulmonary artery catheter is going to be in zone 3 of the pulmonary artery. Not on the left side heart. It's zone 3. It's not there. Okay, it's in the pulmonary artery, which is a vein. It's a great place to obtain mixed venous blood from. Patient has left ventricular stroke volume of 70 mils and a heart rate of 80. What's the cardiac output? Just doing the math there, basic stuff. I don't think they ask you a question like this, but what they might do is then say, okay, so if it's low, what things might you recommend? So kind of a two-part thing. Well, you calculate it to be 5.6, but let's say it doesn't come back 5.6, it comes back 3.2. And you calculated, what would you do based on this? Which are the following? So they're asking, be kind of like more. This might be part one of a two-part question. Which of the following echo, so cardiac ultrasound, echocardiogram findings are consistent with diagnosis of systolic heart failure? A decreased left ventricular ejection fraction. Remember, said normally, I said 65 to 70. Some of the books will go 60 to 70, whatever, but you get the idea. 2/3 to almost 3/4. This is below 45%, significantly decreased. Decreased left ventricular chamber compliance, decreased left ventricular end diastolic volume, etc. Let's look at the general feedback. So key echocardiographic findings in systolic failure, decreased left ventricular contractility include increased left ventricular end diastolic volume, increased left ventricular end diastolic pressure, and 3, a decreased left ventricular ejection fraction, less than 45%. Decreased left ventricular chamber compliance is characteristic of diastolic, not systolic failure, in which pulmonary artery pressures can also rise. We're making that distinction there. The normal range for pulmonary artery or pulmonary capillary wedge pressure, as measured by the distal port of the PA catheter. Remember, the distal port is, we're not drawing bluff on that, we're measuring now. What the balloon inflated is, and again, this is what it is 6 to 12. And again, some of the books say 5 to 12, a little bit of variation, but MBRCs shouldn't mess with you with that. That should be fine if you're close. But you got to know what the values are. Reflects downstream pressure of the pulmonary circulation, pulmonary venous pressure. Pulmonary venous pressure in turn reflects left atrial pressure, which ideally equals left ventricular diastolic pressure or left ventricular preload. Thus, pulmonary artery wedge pressure or capillary wedge pressure provides a window to left-sided heart function, particularly left-sided diastole. In patients with chronic respiratory disease, pedal edema is a sign of impaired pulmonary diffusion, hypercapnia, impaired CO2 removal, right ventricular hypertrophy or failure, systemic hypertension. Let's look at the feedback. Patients with chronic respiratory disease typically are chronically hypoxemic. Chronic hypoxemia causes vasoconstriction, which forces the right ventricle to work harder than normal over time. Well, by the way, the other thing that forces it to work harder than normal is a lot of those patients will have secondary polycythemia. So they'll have vasoconstriction and thicker blood. Just figured I'd throw that in there. Over time, this increase in workload may result in right ventricular hypertrophy or failure and poor venous return to the heart. When the venous return to the right side of the heart is reduced and CVP increases due to the backup in the event of the pumping, the peripheral blood vessels engorge, resulting in accumulation of fluid in the ankles, feet, etc. A condition called pedal edema. That's a pretty rich definition there. 52-year-old male, ARDS, sepsis, not good, right? Admitted to the ICU. Blood pressure is 80/50. So critical level, just be clear on this, a critical level for systemic blood pressure, you want your systolic north of 90. Okay, 90 or north of 90. North of 90/60, something along those lines. But this is 80/50. It's below that threshold, critical. Norepinephrine therapy has just been initiated. INR is 1.5. You need to know your INRs, you need to know PT, PTTs. Platelet count is 70. Normal low-end platelet count, depending upon which book you look at, is 130 to 150. Okay, up to 450 to 500. So this is low. This is low. Which of the following should be done next? Transfuse platelets, infuse the same next, not down the road. Give them platelets, infuse fresh frozen plasma, insert a radial arterial catheter, place a pulmonary artery catheter in place. Okay. An indwelling arterial line will enable continuous blood pressure monitoring in a patient receiving continuous vasopressor. There's no signs of active bleeding, even though the patient has a platelet count that's significantly below normal. Prophylactic platelet administration is recommended for more profound thrombocytopenia, low platelets. There are no signs of active bleeding. Transfusion of blood products carries risks. Outcomes are not improved by pulmonary artery catheterization, which has risks with the placement and the use. With that, we have some references here that may or may not be useful to you. Again, PubMed, Medline, those are where you'd go there for the original research. AARC has some great guidelines, and then a couple of my textbooks here as well. With that, I want to thank you guys very much. And hopefully you enjoyed this. Hopefully you got something out of it, and it will help you for those exam candidates prepare and pass the exam. Thanks a lot and have a wonderful day.